damp and chilly, but I've got to say it's lovely to be in this warm, this magnificent town hall, and it's always great to be back in Kensington in this royal borough. And my thanks and appreciation on behalf of the whole committee to Lucy and for Maxine for all the work that you guys have done to welcome us this morning. So I know, Maxine, that you have another meeting and you have just taken a couple of minutes out of that meeting to join us, to welcome us. The last time we were here, you were telling us about how closely the local government and NHS are working together and the work that you're leading towards that. And it'd be good to hear some more of that. And it'd be good to have you say some few opening words to welcome this committee formally.
Yes, thank you very much, Councillor Shepp, and welcome everybody to Kensington Chelsea Town Hall. You are really welcome here. Yes, it was I think it was September 2023 when you were last here. I was looking back, and my goodness, what a lot has happened since then in the world of health and social care. And as Rob and I were just saying outside, and I'm sure you will talk about this morning, you know, we are in a time of enormous change within the NHS, within ICBs, both in terms of for our residents collectively, but also in terms of the structures of the organisation around that. And I know that as council, that's when scrutiny comes to the fore, isn't it? And over this last year, you have scrutinised so many things that are important to our residents, you know, from mental health to palliative care to all of the priorities within health, within the health and wellbeing across the 8 boroughs. And it feels even more important than ever to have that focus and that scrutiny, and to be absolutely keeping residents and residents' long-term health in mind. So I understand today you're looking at planned and elective care, and that shared objective across our 8 boroughs to get those waiting times down, make sure that our residents can get the surgery that they need when they need it, and to get some consistency across wait times. We all recognise the struggles that our NHS colleagues have to do that, and I've witnessed firsthand, as I'm sure many of you have, some of the really creative things that are happening in the NHS to make sure that you get seen quickly, but that is still not a consistent experience across all of our residents. And you will also see in your casework, I know, the impact of when residents can't get the treatment that they need at the time that they need. It leads to long-term sickness, time off work, impacts on families, issues with housing, and all of those kind of holistic things, which is the lens that you as members look through. So you've got lots on your agenda. I won't take up any more of your time. But I hope you have a really good session this morning, and I look forward to the next time.
Thank you very much indeed, Maxine. So grateful to you. Lucy, a couple of quick words from you, then we'll begin with the formal agenda.
No, it's just great to have you all today, and looking forward to this meeting. Thank you, Maxine, for coming along. I'm sorry we don't have as good snacks as Westminster usually. There's but there's nothing around. But hopefully we can have a really positive meeting.
Thank you very much, Maxine. Thank you very much, Lucy. And we'll see you very soon, Maxine. Thank you.
Right out.
Thank you. So we're very good to be back here, as I said a few moments ago, and it's really good to have Concia back after her maternity leave. We have missed you, and welcome back, and we are looking forward to having your contribution going forward. And it's always good to have our NHS colleagues, particularly Rob, the Chief Executive, and other senior colleagues. I think 1 or 2 of you are here for the very first time, so a very warm welcome to you too. Good to have your attendance this morning. So I am going to, colleagues, I'm going to rejig the agenda slightly. I know that Rob has to be elsewhere for another meeting, and it's really good to have you, Rob, attend in person, despite you having a diary clash at the very last moment. So we will slightly rejig the agenda to take Rob's ICB update to begin with, and then we'll come back to the agenda items. But before I do so, let me just take apologies first, please. Who's going to?
I think Councillor Dennis has sent his apologies.
That's right.
Councillor Nagra is running late, but she should be here shortly.
Thank you very much. And the item number 2 is declarations of interest. So let me start with mine. So I'm the lead governor of Central and Northwest London NHS Foundation Trust. Any other declarations? Yes, Ben.
My usual declaration of interest. I'm employed by the Nursing and Midwifery Council.
Thank you very much for that, Ben. Anybody? Yes.
And I'm employed by West London NHS Trust.
Thank you very much. Anything else? Anybody? Thank you. So the minutes of the previous meeting, please. They are here, and thank you to our Westminster colleagues, Linda and your team. Thank you very much for putting those minutes together, and do pass on our thanks to them. And if it's okay, shall we take those minutes as tabled? Yes.
Yeah, sorry, I just have a follow-up question relating to some of the actions agreed at the meeting. In the North of London Winter Campaign and London Ambulance Performance Update, there were some actions. I just wanted to confirm that this has been followed up. In particular, the 5.15, the community will receive a breakdown of GP face-to-face appointments across the North of London NHS 8 bars. Which is one to.
I will have that shortly, and I'll be circulating them to the team. I'll be working with Rory and Liz on that, so we'll have that to you shortly.
Thank you very much. And there are other actions as part of this.
Never hand them. We'll have that after shortly. I'll circulate to the committee.
Thank you.
Okay. Thank you very much for that. And so the next item is London Northwest London Planned Elective Care Strategy. But as I was just alluding to, we are going to park that for a moment and take the ICB update. And before I introduce Rob formally, let me just pause for a moment and say there has been some changes in the Northwest London, but much more wider in the NHS England leadership. So you will have heard that Penny Dash, who used to be the chair of the ICB, is going to be the next chair of NHS England. And we pass on our congratulations to her on a recent appointment. And you may also have heard that Tom Kibasi, who is the chair of a number of NHS trusts within our geography, is going to be leading on the 10-year review. So our congratulations to Tom Kibasi as well. So with having said that, very welcome to you, Rob, and your team. And if you want to give us a quick overview of various different items by way of update, please. Thank you.
Thank you, Chair, and I appreciate that committee's time is limited, so I will, as usual, take my written report as read and welcome any questions, and hope you spend most of the time responding to any questions that you have. Just make 2 or 3 headline points, if I may. I think important to keep our focus on issues around mental health in the sector, and where we are in terms of working towards a decision around adult mental health services. We will shortly be moving on for the year ahead to a more focused work around children's mental health services. So just to signal that for potential future items over the months ahead. We also are continuing to draw out our intentions to improve same-day access in primary care, the development of integrated neighbourhood teams, a focus on organising ourselves in health and care around our residents and neighbours across the 8 boroughs, and that is a key strand for the period ahead. I won't say any more than that, but we have our 9 priorities that we have on services, and I've just drawn out a couple there that I think were worthy of bringing out here. I need to say a few words now on money, and I'm happy to come back in future meetings in terms of sort of giving more depth to this. But for the 4th year on the trot, we are heading towards the end of March, where North West London Health, on its £6 billion health spend, is living within our means. We will be breaking even. That has been in spite of some challenges in some parts of the forest in terms of not hitting plans. But overall, we've done that, and we will be potentially receiving responsibility for an additional £1 billion on top of that. It's more like £7 billion for specialist commissioning services from the 1st of April, and further responsibilities on immunisation and vaccination commissioning coming to us following dentistry, optometry and pharmaceutical services that were put into our responsibility. However, despite us delivering on that, the wider NHS and indeed ourselves are struggling to hit a balanced position for next year, despite significant funds coming into the health service and overall real terms cut. And as I've mentioned this committee before, North West London being the only ICB in London that is below target on its funding, and some £176 million if we had received fair shares funding, and we have of the order of that level of gap for next year. So were we able to be funded at that level, we would also have a balanced plan for the year ahead. But because we haven't, we are currently working through how we balance for the next financial year. Given the scale of financial challenge, I know the central team, you've alluded to it already, are very worried about this, and particularly the overall financial climate, and are signalling significant potential cuts going forward, including potential significant impact on integrated care boards and the scale of integrated care boards. The reason I'm having to leave early is because this is not this is all being announced today and this morning, and I'm being called away to meet the central team on what that actually means in practice for the immediate term period ahead. But I would imagine a significant downscaling of NHS England and the ICB infrastructure and our ability to consult and engage with the population from where we currently are. The only final thing, and this was just by way of chair signalling things that you may wish to schedule in for future meetings as well. So I'd imagine that would be one. And also on the new hospitals programme, we've had the news of Hillingdon Hospital staying on the
Good news for Hillingdon.
Very, very good news. Not such good news for our Imperial College.
Absolutely, and I'm sure Nick, who's a member from Hillingdon, is not able to join us. He's been taken away elsewhere, but I'm sure he would be flagging that up as a good news for residents across North West London, but particularly for the neighbourhoods in that particular geography.
Indeed, but the sort of plans for the Imperial side of the new hospital programme are something we are obviously working through. Very happy to keep this committee briefed during the course of the year on what we intend to do about that. I could talk a little bit about Mount Vernon, but I'd include that in maybe updating you when we come to the detail on that and what's happening with the cancer services at Watford and UCLH and the services at Mount Vernon side. So I acknowledge something we need to keep you informed about.
Great. Rob, again, thank you very much for that quick run through key items of important emerging stories that is concentrating all over minds. So thank you very much indeed for that. So there are going to be some questions before we move forward. And the first question is going to be from Natalia. Natalia, good morning to you.
Good morning, and thank you very much. Thank you very much all. Yes, so I've got a question in relation to the ICB's GP Access Enhanced Service for 2024-2025. There has been a commitment to allocating 6.6 million to improve access to general practice. Prior to this meeting, I was approached by Dr. Carla Kramer, who is the chair of Hamilton and Fulham LMC. She has raised some concerns. They remain concerned about delays in utilizing these funds, particularly in the second phase, which requires PCNs to demonstrate a 10% increase in activity. She believes that this expectation is seen as inappropriate given the pressures on GP practices already providing a record number of appointments. I want to convey her question, please. So I'm just going to read a piece of her email, which says, despite 44 PCN applying for this funding, delays in developing and approving the specification have resulted in a significant portion of the 6.6 million potentially being returned to the ICB baseline to offset its deficit, thus being lost to patient care. Late notification of successful bids additionally results in increasing pressure for PCNs to deliver schemes in year. So there's an urge, Mary, they want you to please confirm and ensure that the full 6.6 million is retained for the use in general practice in 2024-2025. And I understand there have been other doctors as well expressing very similar concerns. So can you please give us an update and reassure us that our committee is in place?
Okay.
Thank you very much.
I'll try and keep the response brief, but I understand you welcome the question and are able to sort of respond to it, because I know it's been a theme of previous meetings as well. In overall terms, we have significantly increased 7% year on year real terms investment in primary care up to 1.1 billion in total overall. 6.6 million, which we set aside, and this committee is well aware, to spend the year on engaging better than we had before on what same-day access hubs, how they would work in practice at a practice level, and how PCNs would organise themselves. We were also had our feet held to the fire and make sure we got value out of that 6.6 million in terms of were we just going to allocate it out and have an unclear plan in terms of how we were going to get improved same-day access. So yes, we put in a fairly rigorous process to assure ourselves that spend on same-day access would actually be enhancing same-day access for our residents and patients. Yes, we were fairly challenging to the 46 PCNs around whether we could see the evidence of that in front of us. And as you know, we had a first phase where we spent the money on the engagement and the questionnaire and the events that when we went out into communities to talk to them. We then had the Pathfinder process of specific initiatives across the 46, of which we had all but 6, I think, in the end, where we supported funding to go in. We are estimating going to spend 4.7 million up to 6.6 million in total, so a fair portion of it by the 31st of March. We will not be carrying that money forward into next year. We're not able to, but it does sit within the overall pot, as I say, of increased investment. It's not lost to patient care. We've actually significantly increased the investment in patient care year on year within the overall funds that we have. So in effect, the difference between 6.6 and 4.7 has been used on other healthcare services in the year during the course of the year, not lost to patient care. And the increase in spend and the increase in appointments that we had into primary care, both virtually and face-to-face, and with the significant increase in additional roles and responsibilities that multidisciplinary staff in primary care. And the good news that our GP numbers have stabilised, have been falling with lots of the age profile, whereas I think we've seen a reversal of the trend of a fall and turning into an increase over the last quarter. So we've got more GPs on the patch, we've got more multidisciplinary staff in primary care than ever before, we've got more spend than ever before, and in that context we must make sure every penny is used to improve access for our residents, and we haven't felt that good value would have been achieved between the difference between 6.6 and 4.7 in that environment.
Thank you for that. Ben, I think you wanted to ask a follow-up question, is that right? On that particular point.
No, questions on other issues.
Fine. Okay, fine. So your question then, please.
Thank you. Rob, appreciate it's a really uncertain time, and I think obviously we saw the news overnight with the Health Service Journal sort of trawling some of the issues around 50% cuts to the ICS, which you alluded to in your opening remarks. I just wondered if you could talk a little bit more about what the impact of that would actually be in relation to the ICS. Appreciate it's a hypothetical situation until there's any announcement, but wonder if you could talk about that, and also interested to know about the status of the Mount Vernon Cancer Centre project. So myself and a number of other colleagues around this table are obviously on the JOSC in relation to that issue. So it would be good to get an update on that too, please.
Thank you for that, Ben.
Thank you. So I hope the committee would appreciate the difficulty of the position I'm in a public domain meeting of effectively an in confidence information that was shared with myself last night, and I'm off from here to find out what the actual official announcement is, and that has been in the public domain in the press. But I would wish colleagues to be aware that there are thousands of healthcare staff affected potentially by what we are talking about at the moment, and we need to be respectful of what that means. However, I think, as I said in my opening, that it is clear that the health service is not planning to live within its means next year based on the submissions of plans overall, and it is clear that the government is very concerned about the scale of gap that we have and the need to focus any pound that we do spend on frontline services. And the ICB, NHS England are not frontline services, and indeed providers have staff who could not meet the definition of frontline services, and nobody so today's headlines are about ICBs, last week's headlines were about NHS England, next week's headlines I'm sure will be about providers. So it's not picking on any part of the system in particular. It is a stated intent to remove money from the bureaucracy and invest it into frontline services. In terms of the impact on ICS, you have to then say, what does an ICS do? What is it for? And therefore, what is that going to do to its purpose? And our formal accountable officer purpose is to be the custodian of population health, improvement in outcomes, reduction in inequalities, value for money from the £7 billion, and working on the wider determinants of health in partnership with local authorities. So clearly our ability to transact that, all of those things, and our legal duties towards public consultation and engagement, the resources that we currently spend on that will be significantly depleted. And that's what we're going through at the moment, is how we are going to do the requisite reduction in function with the likely resource. But this is not set in stone. It is speculation at the moment, and we await a sort of official announcement.
Grateful to you for that very helpful reply to Ben's question. Ben had another.
Sorry, I'm Malcolm Furman.
Another question around
So,
Malcolm.
so as I said in my opening, I'm very happy to sort of keep, as far as we're concerned, the process of the consultation and the plans for Mabo and the cancer services are still in tray. There are I have to remind myself exactly where we are with the decision-making business case, which is making its way through, and I hope you'll be aware of that in your scrutiny role. And I think it'd be fair to say it's an ongoing basis, because, particularly in the financial climate of how the funds for the different elements of that need to come together to meet Plan A, I would say there's a high degree of uncertainty as to, therefore, how that's going to continue to move forward. And therefore, the importance of us working on the Plan Bs and what the sort of inevitable impact of that flows to local hospitals, which we are working through, and indeed have made investments in local hospitals to respond to that.
Then you wanted to come back with a supplementary.
Just on that particular point, I think it would be helpful if we could, in advance of the JOSC, specifically on Mount Vernon, and ask for details around what that Plan B looks like, because I'm not at all clear.
Sure.
I don't feel that I'm able to scrutinise something that I'm not clear about.
Okay, so thank you very much for that. Jacqueline has jotted that down, and I think Tommy has also, so we will follow that through. Thank you very much, Ben, for that. So I'm now going to come back to you if you have any other questions, but make some progress now. So Chetna, please, your question.
So thanks very much for this report. Congratulations on the new appointments for people who are going to be contributing to the NHS. I'm just mindful of the changes that you're going to be announcing and the way it's going to be announced, because a lot of people are going to be threatened by that, and you may potentially lose very good team members, very good staff. I'm just mindful about how that's going to be managed, because overnight you could lose. I don't know what the cuts are. I'm guessing there may be potential jobs that may go. Just mindful that that is carefully managed, and how you're going to do that. My main question is on the NHS 10-year plan, which I'm mindful that might be changing as well. You mentioned Health Watch in Brent, Westminster, and Kensington and Chelsea. I just want to make sure that all the boroughs are included within that you're doing that piece of work, because as well as the vote, I can see that those health watches are being funded, but I just want to make sure all of the boroughs are.
They do it on behalf of, so we follow them on behalf of
It's very good clarification. Thank you. And I hope we get to hear more about what the longer term plans are going to be.
So Health Watch was scheduled to be here this morning. Unfortunately, I guess maybe we don't know, but maybe transport issues or whatever. They are not here, but maybe they might be running late, and they might in fact join us later this morning. Hopefully they probably may. Thank you.
Thank you.
Okay, so I don't know if you want to comment on anything else. So before we move forward,
if you want me to, 64,000 people work in health and care in North West London. What we're talking about here is what non-frontline staff. I'm not going to debate what is a non-frontline member of staff, because as far as I'm concerned, we're all frontline in trying to serve our residents and public. But others will have definitions of that. Of course, that means if this is the reality, we are going to have continued significant job losses in non-frontline staff. And of course, we take our responsibilities to our staff deeply seriously around the processes of communications and support to the staff that are affected by that, which is why I was hesitating in what is not in the public domain at the moment in a public meeting discussing this. But
I think, Rob, thank you very much for that. But I think maybe once you have had the opportunity of having this meeting that you have referenced, perhaps you come back to the committee and perhaps give us meaningful update where we can then ask some important key questions.
When I have the information, you can have it.
Thank you very much indeed. Okay, Chetna, thank you very much. If that's okay, then I'll move forward.
The next report will be mindful because it's just helped us report the truth back to our residents. That's all we're wanting.
Of course, thank you.
Yeah.
Thank you very much. I'm going to make some progress if that's okay with you, because I'm mindful that Rob might have to leave any moment now. So then, Concha, thank you very much for waiting so patiently. Your question, please.
Specifically around prevention and work's being carried out to target young people and families. What does that look like? And sort of probably a bigger frame around this is looking at some of the changes specifically in Westminster, but it could affect some of the other boroughs with the decisions around HCL and cutting a frontline role, which is social prescription, from Westminster in completion, and that's from the arts budget. So is this something that could then happen in other boroughs? And I think that's something we should be mindful of as a committee. So as I think of prevention and the role that's preventative, where is this heading? What are the conversations like with HCL? Have you had much in sort of conversations? What does that look like for you? And just generally the arts budget, I know that this has been really helpful to support residents, and if we're starting to remove whole roles from the system at this stage, it's just a little bit concerning.
Thank you.
Okay, so I'll try. I mean, it's quite a big question. I'll try and break it into big things. So our strategy around prevention, young people and families is integrated neighbourhood teams, family hubs, and having joining up the community, mental health, primary care services, and targeting that and targeting the whole vaccination prevention through those integrated neighbourhood teams. If you're alluding to this, is the money situation going to be leading to us cutting frontline services? Generally, no. What I've been describing in terms of funding is around the support services and the back office functions. And in fact, the investment into our strategy remains and continues to be growth in investment in prevention out of hospital, and that stays the same today as it did before. And in fact, the reason for the focus on non-frontline reductions is to uphold our commitments to those frontline services. I would have to come back on the specifics of social prescribing and HCL, because I would not be giving a full answer to respect the question. You have to give a written answer to the specifics on that.
We will take that. We will follow it through. Thank you very much.
I guess for me, the arts budget overall and around preventative roles, so social prescribing is one of them.
Yeah.
But of course, there are other.
So our overall strategy is to increase that. Without going into the detail underneath that, I wouldn't be respecting the question without being able to get the information and provide that. So I'm not saying there won't be ups and downs within that overall intent to invest more.
So thank you, that's helpful.
And I know for a fact that the social prescribing in Westminster is absolutely amazing, and thank you very much to those people who do such sterling work day in day out, Kocha. Ben, you will have one or two other questions.
No, I think I'm fine actually.
Okay, thank you very much. Any other final question for Rob? Okay, very well. Rob, thank you very much.
I'm very sorry I have to leave, but we have a capable team here on planned care. So
thank you. We leave you to our next meeting. Thank you very much for joining us. Grateful to you.
Well, we should say we appreciate how enormously stressed it is.
Absolutely.
Yeah, slightly to the bottom rocks.
yes.
So we do appreciate, as Claire is saying, and we also appreciate the work that your team are doing around finances, around budget, which is very much appreciated. Thank you very much. See you until next time. Okay, so we now move forward with our next substantive paper. And thank you very much to the colleagues who are, I think, coming for the very first time. And it's always good to have your company. And I don't know which one of you are going to be leading, or maybe you're going to do a double act. But James, okay, we will start with you, and then I'm sure Tina will want to supplement or complement what you're saying by way of opening remarks. Thank you.
Thank you, Councillor. For people and colleagues I haven't met here today, my name is James. I'm the Director of Strategy and Transformation at London North West Healthcare. We, within the acutes in North West London, have a partnership arrangement you might have heard referred to called the Acute Provider Collaborative. And that's the partnership between Imperial, Chelsea, Hillingdon and London North West Hospitals, but also working with very closely with our Integrated Care Board. And this piece of work I'm presenting today or leading today because this part of the joint forward plan and the work together we're doing up in a very joined up way, because what needs to change isn't just within one part of our NHS system, it's thinking about all of the different impacts on how patients who need outpatient care, who need specialist care, who need planned procedures like surgeries, how we provide that in a joined up, timely, equitable way. I'm not going to go through all of the detail of the paper, just a few things to emphasise, but before questions. This strategy is linked to the joint forward plan that you might have discussed and seen at different scrutiny boards that the ICB, working with all sorts of different partners, including local authorities, has put together on the priorities for how we're going to improve health and care and wellbeing in North West London. And one of those priorities was transform plan care. And this is a setting out and starting to understand what are the biggest challenges and where do we need to focus on over the next few years to achieve that objective. Where we are at the moment, this is very early stage. I'm not here to present recommendations or answers. It's actually looking forward and hoping to hear some of the experiences from your communities, your residents, and some of the challenges. And we're really trying at the moment to understand these are the biggest problems, these are the biggest challenges or priorities for people in our local communities. We've been doing a lot of engagement, including with local residents. Some of the material we shared with the paper around the issue paper, inviting comments through surveys and online surveys. We've held resident forums and inpatient events. We've also been engaging with clinicians and professionals across our different organisations, including GPs and some of the consultants and specialists who work in our hospitals. And those giving a sense of these are some of the biggest things that are getting in the way of high quality, timely, equitable care, some of the ideas to make those changes. We've got lots of different ideas we've heard so far, and I hope a few more come out of discussions today. Some of the emphasis that's come through that engagement very much around is very, I was thinking of the residents forum we were on last week, some stories with local residents were describing when we got to see the clinician, when we got to see the nurse, it was really high quality care, but the communication before we got to see the appointment about how long I've been waiting, which day I needed to come, that you sent me 4 different messages and some of the information wasn't always accurate. When I tried to call to find out, no one could help me. Some of the biggest frustrations. So that's clearly an area we need to do much, much better on and much more quickly. We've also heard a lot about people wanting to have the support around their needs and how we work across. You might have heard in this committee or other areas around the idea of integrated neighbourhood teams around working with local communities with some of the services closer to people's neighbourhoods and some of those connections and how we can provide more specialist advice to people's needs earlier without having to be referred into a secondary care setting, so a hospital or acute setting. So thank you very much.
Thank you very much for that very comprehensive update. I don't know, Tina, if you want to add anything to what you have just heard from James, please.
Just a couple of things. So, hello, I'm Tina Benson. I'm actually the Chief Operating Officer. I was pleased to be promoted to CEO, but I'm not sure that Leslie...
But since you're coming for the first time, we will give you a little bit of a head start.
But I am here for the CEOs who from the acute providers, so Pippa, Leslie and Tim, because they've gone to the same meeting that Rob's gone to, so I'm here. I think the other thing, just the thing I would add is that we do not want to be hospital-centric in this, and I think Rob's leadership has allowed the time and space for all the partners to come together to think about what do our population actually want, as opposed to what do local authorities and acute trusts and community trusts want to provide. And so I just thank Rob for his leadership on that, because this is the first time, I think, where we've had a real multidisciplinary approach, including our patients and public and population, to design a strategy. Because if we carry on doing what we've always done, our waiting list will grow rather than getting shorter. We'll be seeing the wrong people in the wrong settings. So if we have that in our minds about what do our residents and population need, I think this will be a really good strategy and good way forward for the next 5 to 10 years for the North West London health and care partners.
Thank you very much for that, Gina. Rory, also good to have you company, as always, good to have you back. I don't know whether you want to add anything from the comms engagement perspective.
Yeah, I mean, I think James has alluded to the kind of feedback that we've had, largely being around the way in which people are communicating while they're waiting, and things like not knowing the length of wait and things like that. So I think he's summed it up quite well. I don't think there's anything in particular to that.
Great, thank you very much to all three of you. So there'll be surprisingly some questions. So the first question is from Lucy. Lucy, hi.
I've got a few questions, if that's
Great.
okay. I think just starting on communications, we're interested to hear about what work you're doing at the moment to kind of provide better communication, just because I think that's when someone's been waiting a very long time to receive the care or appointment that they need, that anxiety can really add to it. So I think that's firstly something I would love to hear about from you. Also, just generally whether we think you feel it's realistic target to reduce backlog, given that at the moment our waiting lists are rising, and how confident you're feeling about that.
So let me take that and then come back to you. Okay. So Rory, if you want to kick start, and then I'll get the colleagues in.
So my focus has been very much on getting the information about the issues paper out to the public, going through all our different channels. We held a residents forum, we've been going out talking to different communities in all our boroughs, that bit of it in terms of talking about the problem, if you like. More widely on terms of the communication with patients while they're waiting, it sort of sits with the providers, but that is part of that. So probably better for colleagues too.
Thank you. And James, perhaps you can answer from the North West London hospital perspective, and maybe Tina from the Hillingdon hospital perspective. But again, if you could just reply in a sense, how is it looking in different parts of the geography place? What is the experience like?
Yeah, so I'll start from a North West London perspective, and some of this analysis was in some of the papers we were able to share. So waiting lists have risen. There's no surprise, we've seen that nationally, but over the last year, they have actually started to fall. For the first time, we've been able to see and treat more people than we have been having people added to the waiting list. So we're starting to see that decline over the last year. That's been achieved with some extraordinary efforts from colleagues, and some of those extraordinary efforts have come at very high cost financially as well. So there's a question around how sustainable is that over the 5 years to keep on working in that way. And that's where we need to think about productivity and how we get more productivity, but also how we meet needs in different ways rather than needing to be a referral into secondary care. And the aim of the strategy being, where do we put that emphasis? And that's where we want to hear someone else, is to get that balance right, to work towards achieving the goal that we want all of our patients have that timely care and be meeting the NHS constitutional standards. Within my hospital, or our hospital, the hospital I work at, London North West, we've seen that same pattern. We've seen our waiting list is one of the highest in London. Some that's been impacted by causes of that, as well as sort of growing need in our local boroughs. Also, some of the changes inside the hospital about how we're providing, been investing in services for the future that's caused some of the delays. With that, we've been putting in some of the, just to touch on communication, some different ways of communicating with patients to keep them updated. An example of that is where we're now texting and contacting patients who have been waiting a long time to say, do you still need your appointment? Your need might be resolved itself. You might have actually sought for access treatment elsewhere. And that communication back and forward, as well as one step, then means that patients aren't waiting and being sent for an appointment. And they're also having that regular contact where if they say, no, I do still need that appointment, they know that we're still waiting, we can update them, right? Some of those areas. So that's one of the types of interventions we want to think about.
Thank you for that, James. Tina, please.
Thank you. So I probably should have said that I lead across the acute provider collaborative for elective care from the operational perspective. So we're trying to do a lot. We absolutely recognise our communication from a hospital perspective with patients is poor. I'm sure you've heard residents telling you that they get 6 letters, they don't know when their appointment is, and then they get told they didn't attend their appointment and they've been removed from the waiting list, because we hear that as well. So we know our communication is not good enough. We're doing a few things. So we are focusing at the moment particularly on our deprived populations because they have a higher incidence of missed appointments than others. So we're working with our third sector charities, which actually was funded by the ICBs as a project last year, to call those patients and to not ask them, are you coming to your appointment, which is our traditional way of communicating, but questions like, do you know how you're going to get here? Do you understand why you're coming? Will you have any issues coming away from work? We provide you with an appointment at a more convenient time for you. And those have had, we've only done small cohorts so far, but we have seen some improvement in our missed appointments. And so we're going to roll that out over this coming year to really help those people where we know we cause health inequalities. So that's one project that we've got up and running at the moment. The other one specifically is around a digital portal where people can make and change their own appointments. So actually some of that communication isn't required because they've done it themselves. And so we will stop some of that communication, but obviously that only helps a particular people who are digitally enabled. For those who aren't digitally enabled, the problems that we have at the moment still exist. We're also piloting, as bizarre as it sounds, communicating less. So some of our patients, particularly Hillingdon, have said they get 2 letters, 5 text messages, and they just don't want that. They just want one thing, one piece of paper and probably one text message. And so we're trying to streamline some of that. So lots going on because we recognise this has been ongoing for a long time in terms of communication with our patients.
Lucy, please.
And then just kind of moving on to alternative strategies and going to CDCs. Which I know is sort of an area which can provide big improvements. And you came to our select committee here back in July last year, I think, and we sort of sent a letter, we had a few follow-ups just in terms of steps going forward. But a couple of things I'd be interested to hear about is, are you planning further expansions? Being considered for CDCs in 2005. We had sort of obviously spoken about it at RBKC side, but I don't know if that's the likelihood of that. We'd be interested to hear from that. And then also, what's been the impact of the January 2025 increase in CDC operating hours on patient access and wait times, just to see if that's had an impact on what you're seeing in terms of the data, and are there plans to introduce new surgical hubs for specialism facing the West, please?
Thank you for Lucy.
Sorry,
yes,
yeah, so that's absolutely fine. It's just coincidentally, I'm also the SRO for the CDC.
Great.
So is there expansion plans? We have put in a
So
bit.
CDC, by the way,
Sorry,
is Community
Community
Diagnostic
Diagnostic
Centres.
Sorry, yes.
By the way, anybody tuning in and not knowing what we're talking about.
Apologies, yeah.
And SRO is a
Jargon.
Senior Responsible Officer.
Thank you, councillor. So we have put in a small expansion plan. So the monies for expansions were specifically around pathways. So if you look back, the community diagnostic centres were very much for getting early diagnostics, particularly for cancer patients, but more broadly for the population. I think what happened initially was we used it as additional capacity, and now we're really refocusing it on what pathways do we need so that we can manage patients in primary care if they have their diagnostics. So we're trying to refocus. So we are looking at, so we've now got asthma pathways, we've obviously got the targeted lung health pathways, we've got women's health pathways. So we're trying to change our focus a bit. So we are looking for some expansion monies, but that will depend on where we land with what the financial position for the NHS, whether that happens or not. In terms of the extended opening hours, I haven't seen any data yet. It's probably a little bit early to say whether it's working or not. We do know soft intelligence, patients say they like it because they can come in the evening, and that is the research worldwide. And then surgical services, we need to use Central Middlesex Elective Orthopaedic Centre more as we move forward into the year. So I think what we will probably do as an acute provider collaborative is spend our effort and energy getting what we have already working, whilst we think about, given the financial position for the NHS, what else might we consolidate that is more efficient and gives better care to our public.
So in all of this work, Tina, before you finish, how are you ensuring, going back to the point that I just raised a moment ago, that the experience is pretty much similar, whether you live in Killington or whether you live elsewhere in other part of our geography?
I mean, as you will know, so we do quality assessments for any change that we're going to make, and we absolutely would bring any changes through either the local committees or through to here if it was a big North West London change, because obviously health inequalities, we know exactly the parts of the population that already have poorer health outcomes. So we do all of that work exactly the same as we did community diagnostic centres, and we keep revisiting that because it is complex, and obviously it's not just looking at one dimension of inequalities. There's lots of dimensions which are intersectional, which we haven't looked at as well as we would like to. So I think no other changes planned at this time, but that's the process we would go through if we were going to make any further changes.
Thank you, Tina. James, please.
Just expanding on the surgical hubs with the strategy. The first is that in the analysis that's coming through, actually, most of our waiting list and patient needs is outpatients rather than surgery. So where we need to really think about some really significant changes would be around outpatients. That's also the first contact many patients have before they would have a surgery or other procedure. So if we can improve there, some of the waiting time and the uncertainty would help over time. The second is with some of the work across all of our acutes. We've been looking at different pathways and how we can align our best practices together so that the best in one hospital should be the same standard everyone receives and follows. And we've been changing how we've been working to really make progress on that on the last year.
Thank you very much for that. Lucy, did you want to?
I think I'll move on to other people's.
Thank you very much. So we move to Constance, please. Thank you.
Thank you. I have 3 questions, and the first one is around data, patient data and access to care. How have you captured the data of patients that have not been able to access care, even where new models of care already are in place across NWL and they have attended A&E?
Thank you. James?
With our full detail, I do want to have you.
Yeah, sure. So we do regularly look, particularly where we've got specialties with long waits, how many of those patients, if they're on a waiting list, have attended A&E. So we can see that data. I don't think we probably look at it as regularly as it would be helpful to do. But I have to say the proportion of people coming to ED, just very general, and average is always dangerous, as we know. It's quite a low proportion of people on waiting lists. That it does happen, absolutely. But our absolute drive throughout this year and going forward will be to reduce our waiting list and that's why this strategy is so important, because if we don't do things differently, our waiting list will grow, not shrink.
Thank you very much.
So in a sense, do you think that there'll be some values around a recommendation to look at that more regularly in order to inform?
So I think the important thing is that we get our waiting list down, because proportionally, so it's about where we spend our effort and energy. And when we last looked at it, it wasn't a big proportion. There's much bigger portions of people coming into our emergency departments who maybe could be looked after elsewhere. And obviously it's not particularly part of this strategy, but I understand your question. But when we looked at it last, and it doesn't mean we won't look at it again, it wouldn't be our biggest focus. Our biggest focus is just generally, as James said, getting the waits down for outpatients, because I think the anxiety that was described earlier is very much, it's even worse when you haven't even been seen by the specialist who you've been told you need to see. So that's going to be our real focus, and actually is one of the targets in the operating plan for next year is the percentage of patients, the first outpatients under 18.
Thank you. I'll hold that for now and let's move on to my next question again within the strategy. There didn't seem to be much focus on mental health, and that appears to me to be a missed opportunity. And I just wondered how we got to that place, mental health being what it is, not being in there.
Yeah, but if I can start there, so plan care would cover not just in the physical acute hospitals, but mental health as well. This is the first phase of the strategy work where we said we would start with the primary and community services that also connect into our acute hospitals. The next phase would then be looking at plan care in our community setting and mental health settings, whether our waiting lists and access and plan support there. And then for the subsequent phases, looking at some of the connection as well with some of the independent providers. So it's deliberate, not at this phase, but it's the next piece. Once this piece is done, that's the next phase to go.
That's reassuring. Thank you. And my final question, again, maybe a similar answer, it's around accessibility and what's being built in for patients who can't engage with all of the steps that's happening in this process.
One of the, what we're sort of thinking about, what would make a good strategy is around the equity of the care. We would be working with the health inequalities and with some of the patient input, so resident input as well. And there are a number of people who might be having needs across multiple different specialisms, and how we actually think about providing some of that differently. So if you're finding it hard to access one specialism, having 3 or 4 because your needs are more complex and more diverse. And that would also include areas around people who don't speak English as a first language, or support, so areas around learning disabilities or neurodiversity that comes through. And some of the care models, particularly when we talk around integrated neighbourhood teams and that support with GPs and some of the other healthcare professionals working around people, would then help support people. The intention with coming through on the strategy, how that then support people access care in a different way, rather than expecting everyone to follow a traditional pathway where people would have to come into hospital and you have to fit like a square into it all.
Do you have any details on what that looks like?
We don't, because we're at the so it's an issue that is coming up.
Yeah.
Where we are with the strategy is not having all of the answers to the recommendations. So it's useful to hear that as an area to make sure we continue that focus within that is a concern.
So how are you focusing on that, and how are you ensuring that the local groups are part and parcel of that ongoing dialogue?
We've been working with through some of the engagement, the opportunity for different residents and others to be able to contribute towards that. And some of the events, we held an event yesterday with professionals and colleagues and representatives from different groups to contribute towards that, to help with some of the ideas and where this goes. Where it then, with the sort of recommendations, then we're not at that stage yet. We'll come to see you very early on to do some of the listening rather than come and work out all of the answers ready. So I think as the strategy comes towards being recommended, we'll have more answers then on, or more ideas then on, here's exactly how we're going to work. But I would expect some of the work within the integrated neighbourhood teams, and the purpose of the integrated neighbourhood teams is to connect a range of different organisations together around people's healthcare needs, and where people have more different needs to provide support in a different way that's been in the case in the past. And we work closely with that programme as well to make sure any recommendations connect with it to help people access care and are supported to access care.
Great. Thank you very much. Natalia, please.
Thank you very much. Thank you. I'm looking at the diagram 1, overview of improvement proposals. And it talks about digital tools and care using technology to enhance healthcare delivery. Can you please give more information about what this entails and will entail? I mean, I see some of the examples. And then AI listening tools, AI-enabled decision-making support. Just some practical examples, please.
Thank you for that. Tina, please.
I haven't got a copy.
That's right. No, it's fine.
Do you want me to go?
I don't mind. I'll share some more.
So I'll talk about a few things that we're doing. So if I just say, in the organisations across North West London, we have quite a number of small, what I would call small artificial intelligence projects. We call them bots in essence. So they do very focused admin tasks. An example would be if a maternity referral comes in, it translates that into our local system rather than somebody having to see the referral and sit and type it in. So there's some admin type processes we're using AI to be more efficient and more accurate. And then there are some bigger projects. So I would say that artificial intelligence in the NHS, in particular in clinical practice, is clearly we have to be quite cautious with. We have to work with regulators to make sure that it's safe for our population. So an example will be that we're using artificial intelligence to do a first read of chest X-rays for it, so that we can start using our experts, our consultant radiologists, to only look at chest X-rays where there's an abnormality and they need to see it rather than a normal. But these are still in early pilot research type phases. The other things we are doing in terms of, we have some work going on in one of our organisations where we're using AI to predict who might not turn up to their appointments. And therefore we can put an intervention in to help them come. So there's lots of different avenues. We also use some protocolized AI to say whether a referral should be made for a particular specialty in the hospital, or whether actually that patient could be managed in primary care with the right support. So there's lots of different things going on, but we always move. We have an AI policy across North West London that we need to follow and make sure that anything we do is safe for patients, and we will see that grow over time. And that's what we're saying in the strategy. We want to see that grow, but we have to do it in a way that's safe for our population.
Thank you, Gina. James, please. Just to expand with a best practice that's come up through some of our research as well to explore and consider. And it's the idea of, it's called ambient listening. And you might have seen examples of this at Great Ormond Street that have been on the news about how they've used some of the products. Some of your GPs that you speak to might be using some of these same products. And during the appointment, rather than your clinician and the professional having to sit looking at the computer all the time and not really feeling like they're paying attention to the patient, they're paying attention to the computer. The computer is instead able to listen to the recording, provide a summary of here's what we think the note should be, and here are some of the actions from what we've heard. The clinician still is accountable, so they need to confirm that and put that into the record. But it's been very, using Great Ormond Street as the example, is saving about 20% of the time in the appointments. That time saved can be put back into helping more patients more quickly, as well as the benefits of seeing more patients. Some of the experience from the patients have been a much better consultation, because I really feel the healthcare professional is listening to me and able to help me. And from the colleagues who are using it, I'm less burdened because I'm able to listen to the patient rather than having to do so many things at once. So it has some of these benefits. We haven't started using that same software within our acute providers yet because of some of the data security and some of the other parts as well. So we're wanting to make sure when we're using some of these tools, it's got the patient security and information has to work within our cyber and our other sort of patient security, and that's why we haven't been able to roll it out yet. But it's clearly an opportunity to explore and think about as part of the strategy in the future.
Thank you very much, Natalia, please.
In relation to this point, because I know the report also looks to communication, booking, and accessibility, and how there are major concerns for patients. So for patients that, for example, mainly translation services, will the AI technology provide sufficient systems in place to respond to access needs when English may not be a first language and translation is needed? And how is that going to be monitored as well?
Thank you for that. So for translation today, we have live translation services that are used when patients are coming for an outpatient appointment or inpatient care, and they need the English isn't their first language. A lot of the time we'll have calls like Silverlink or Language Line, where the colleagues are able to call, and that can be done by video. It can also be done over the phone, and where necessary, also we'll book in-person translation. There may be occasions, and we need to look at that actually will expand the offer where artificial intelligence tools could help with this. And that's an area to think about, but we want to make sure it's equitable and we're not reducing the quality. It's counterproductive, because if we're not able to have those high quality interactions and understand the patient's needs, all that will happen is either worse clinical outcomes or many, many more contacts, because we're not getting to the root of it.
Thank you. Natalia. Yes, of course.
Thank you very much. In the report also, I say that residents from deprived backgrounds and those like ethnicity are more likely to be on waiting lists, highlighting the disparities in access to care. Have there been an analysis, a granular analysis at the causes of these inequalities and the specific deprivations as well that need to be addressed, please?
Thank you for that. Tina, please.
Yes, so actually Pippa Nightingale, who's the Chief Executive of London North West, is leading a working group at the moment where we're looking at that granular detail and what can we do about it. And obviously some of the interventions that I spoke about earlier about having a voluntary workforce that are calling patients and having discussions with them is starting to give us some rich data. And that's why we've just decided we're going to roll that out further for next year, because we've done quite a small cohort. So statistically, it wouldn't be enough to say this is definitely working for our population. But we're also using, at London North West, they developed what's called an equity index, which also looks at all different types of characteristics where people, which may influence. So and that's how we know in part that the deprived population, and if you're black or mixed race, you're actually more likely to wait longer or have a longer pathway. And so we've also agreed that we're going to look at how do we make sure that all of our patients in North West London, we could look at them with that same lens, because at the moment we're only looking at London North West's data. So I would say we're in the process of doing that granular analysis, and we're also putting in some early interventions to see what works. There's the team at Imperial have also done a lot of work talking to patients to see what would make a difference to them. And so they've been piloting some differently worded text messages, which also looks like it's having some impact. And so what we've agreed to do across the Acute Provider Collaborative is go with these number of different ways of trying to work with patients, because the reason those patients often wait longer is because they've missed appointments on their journey. And so how can we get them to come to their appointments or make our appointments at a time that's suitable for them, so that we shorten their overall journey. So we do understand what the problem is. We haven't yet identified which interventions are really going to make a difference to that part of the population.
Thank you very much for that. Concha, please.
I just wanted to go back on some of the things you were saying around AI in particular, and you may already have an answer for this around looking at the biases in AI and navigating that risk. Specifically, so the answer that you gave, the example that you gave around appointments and missed appointments, biases in AI could create, some interesting situations if there aren't sort of catch-alls behind that. And so I think both the recommendation I would like to make, as well as the question to ask, is what does that look like for you in terms of biases?
Thank you for that question.
So I think that's in part why it's really, really important that we get granular on our data, and that's why we're keen to use the equity index, because what we don't want to do with any interventions that we put in, including AI, is cause inequalities. So I think that there are those processes, and part of the AI policy for North West London is that we do have to have a fail-safe that sits behind it, exactly for the reasons you describe. We're not specific enough at the moment in terms of doing that piece of work. So I think it's a great recommendation that we'll make sure that we reflect. Thank you, Councillor.
Thank you very much for that. Come to Jetna, please.
So going back to AI, so I'm assuming, or I'm guessing, that when people have got multiple languages and English is not their first language, you're going to translate that and they will get those kinds of communications in their preferred language. I don't know if that's a possible solution that you're looking at or considering, but as you say, if appointments have been missed or they've not had a communication, it's because maybe they have, but they haven't understood it in their language. And also, who is a principal communicator, because sometimes not everyone's got phones and technology, and it could be an elected person who does communications on that person's behalf. A lot of the comments have already been mentioned. I want to talk and make sure that the diverse community voices were heard, ethnic minorities, faith groups, voluntary community sectors, disparities you've already spoken about. So James, I know that you're in the listening phase. So, and I think that's a good phase to be in, rather than jumping into all these things. Particularly, what are you doing to make sure the elderly population's heard, where perhaps they've got more healthcare needs? And are you going to access people who wouldn't traditionally be part of these kinds of groups, focus groups? There is probably a larger population that you've not tapped into and heard their voices. So I really want to know specifically what you're going to do about tapping into their voices, and also the younger generation, and how maybe when you're a teenager and you're first starting to step into your own healthcare, going to appointments by yourself, are you hearing their voices? I'm quite interested on what their journey is. And also finally, are there any emerging priorities for Northwest London and our individual boroughs? Because maybe there's some things that our individual boroughs could do with, because it would help us plan our adult social care or mental health or children's care or anything. So just a few things. And I understand you're in listening phase.
Thank you for those questions. Some great questions, and maybe Rory will want to come and pick up some of those questions as well. But let me start with Tina first, and then I'll move to James and then Rory.
Okay, so I'm really interested. The letters or communications in people's preferred languages is really interesting and more complex than you would imagine. So we have been doing a bit of a project on behalf of the APC at Hillingdon about languages, letters in people's preferred language. And what we found interesting is many patients don't want to tell us because I think they're frightened of discrimination. If I'm, that's, and so, or they're saying to us, I'm really happy with my communication in English because somebody reads it for me or helps me with it. So we've been doing quite a big piece of work to try and do that. And that was for appointment letters only, because if you move into clinical information, you have to have a licensed service to translate a clinical letter, which there are actually quite a few of in the country for clinical letters. So we thought we'd start with appointment letters, as you say. Is it because we're still carrying on with our pilot, but we haven't completed it yet. But we found it interesting in this phase of just starting the project that a number of patients don't want to tell us what their preferred language is other than saying it's English. So. And the work that Imperial did that I referenced earlier has really shown that in terms of the diverse population, there is a distrust in the NHS, which you probably hear from your population is probably more than we do. So there's some work that we've got to do, I think, in terms of building that trust and relationships so that they don't feel unconfident to tell us I prefer my communications in a different language. So it's going to be a longer piece of work, I think, than we thought when we started.
Thank you for that, Tina. James, please. Tina's answered the first around the languages. If I take the third around the boroughs, then I'll let Rory answer around the involvement. With the boroughs, at this stage, not yet. I think some of the is coming through is there's quite big differences between some of the specialties. That some specialties are going to need not just the steps everyone's going to take, but some things that could be quite different. And some of that then will impact boroughs because the needs, when we look at the population needs, very different. I know. So Harrow has the highest rate of diabetes in the country, which we provide support with London North West as part of our catchment, the same with Ealing and very close as well. So that would be needing something different for that specialty than in another part of North West London where the prevalence and the need isn't quite as high there. So that will be, I think, as we get through to some of the recommendations, needing to link back to some of those population needs, where there are differences and how that connects with some of the specialties that provide that secondary care support to make sure that that's trending.
Thank you for that, James. Rory, please.
Yeah, it's such a good question. This is what we do. A lot of our involvement approach now really focuses on communities we don't usually speak to, or haven't previously spoken to very well. So, and not just on this. I mean, I'm talking in general. What our focus now is to go to where people are. So most people are not going to come to an NHS meeting or a forum. Some people will, but most won't. So I have a team that goes out into communities, that works with the voluntary sector, works with local authorities and things like how do you reach all these different communities. So older people, obviously, children and young people, still an area for development probably. But we've talked to all sorts of groups. So we talk to travellers, asylum seekers, we talk to homeless people. So it's very different to how we used to do these sorts of things. So very happy to share more about them. Our involvement strategy is actually due for renewal. I don't know what will happen to that now, but the plan is that's to be renewed this year. But that has been really the basis of it for the last 3 years.
Thank you. And through that work, Rory, are you finding the mistrust that Chetna and Tina was alluding to, that you're beginning to make some progress?
Yeah, I think so. So what we're trying really hard to do is to build relationships with different communities. So we can go back to, we don't just go to them once and say, what's your view on plan for care? We ask them what matters to them. So very much that's the aim, and it's a slow process, but I think we definitely have built better relationships with a number of communities. So
Great, thank you, Chetna.
No, I hope we get to see when it's ready, the strategy for the
Yeah.
environment, you know, when
it's
you
very
revise
to
it.
share that, yeah.
Or maybe we can help shape it, I'm not sure,
Yeah.
you know, you can hear the
We're
voice
very
from
happy
our
to bring it
boroughs.
here. And I think also, I mean, we can share, it might be helpful to share with the committee what we're doing up to now, and just the reports on that. So it'd be good.
That'd be good. And particularly you said that the children's voice or young people's voice is perhaps not quite there yet.
I think we did a gap analysis recently, and we thought we weren't probably doing quite enough for children and young people. So there's a piece of work going on to address that. We've done some, it's not that we don't ignore them, but we could do more.
Great, thank you very much. Ben, I'm coming to you next, but let me just take something that you wanted to come in back of Chetna's question, is that right?
Yes, I can do the back.
Okay, please, yes, please do, thank you.
Actually, I have 2 to 3 questions regarding about that first issue paper and the plan care strategy. First of all, as a similar like a Chetna, she said that about the issue paper, especially when might some of the feedback from those responding to the issue paper be seen by this committee?
So we're collecting the feedback at the moment.
Yeah,
that will be incorporated into the strategy.
Yes.
And I think when we come back and share the recommendations on the strategy, you'll see we will be including here's what we've heard on some of the feedback and the issues and how it's informed the strategy.
Is it by next committee meeting we should get that about that one? Our next meeting.
So maybe you can just explain the timeline.
Yes.
Timelines here also. So we're working to have with the ICB Plan Care Board, which is the review for the strategy,
Okay.
looking for that to sign off, working towards their May meeting. And so it would be after that we'd want to come up with the strategy if you wanted to discuss it again, to see some of the recommendations, and that would be inclusive of here's what we heard in the engagement and how that's informed.
That's fine. Just one more
Thank
question, Chair, about the London Plan Care strategy. What role will local authorities and community organizations play in the implementation and monitoring of the Plan Care strategy? Can be more done? Reach out to the interesting groups?
With some of the recommendations I expect will come forward, we've touched on the idea of integrated neighbourhood teams already. So the integrated neighbourhood teams are how we're using services closer to people's homes, organised around some of our primary care networks, and that would include, let's say, local authorities, links with some social care set up, and others within and education, and others you might have heard about the Connecting Children for Health hubs, or the Children Health hubs that I know from some local authority colleagues have come along and been part of. For others who haven't heard about this is when some of the paediatricians from different organisations are going to primary care networks, running multidisciplinary meetings, and just out of those meetings happening, we have the children's social care workers, some of the education contacts able to talk about people, and this is actually, I think Councillor Albert gets to your point earlier about people with complicated needs, how some of that's addressed. So that's something that's come up. It's something that's very clearly an important area we need to think about. How do we expand that not just for children but for other areas? And some of that connection would then need to draw in some of the the local authority services and colleagues who are working with you to join up around that.
That's fine.
Thank you very much indeed. Ben, thank you for your patience.
Yeah, no problem. Thanks, Chair. So I think 2 questions from me. One kind of around the granularity of some of the data. So I just wondered if you'd be in a position to kind of share how the local borough-based partnership populations compare in terms of waiting times and also kind of length of waiting lists, because I didn't see that information provided. And then specifically, and I think this links to a point that Chetna made around kind of the elderly population. Ealing has the highest number of care home beds in the North West London geography. We're also a net importer of care home placements. The impact of that I couldn't see reflected in terms of sort of planned and emergency care within the strategy. And I just wondered if you could give a sense of how that sort of impact will be reflected moving forward and provide any further information.
Thank you, Ben. Gina and then James.
So in terms of your first question about borough waits and waiting times, we have got that data, and the ICB do look at that data as part of the Plan Care Board. I'm sure we could provide you some data if
That'd be
you'd
really
like to
helpful.
see it. Yeah.
Thank you.
James, please.
With some of the nursing homes and the elders, it's useful feedback to incorporate how we think about that, because it's this connection as well with the emergency care is often where we see some infections, but they're within the care homes, actually some of those specialist needs and other parts with chronic conditions as well.
And
Thank you.
just linked to that, could I recommend that you come back particularly in terms of that kind of impact on the elderly population? I just think it's a really critical point for us to ensure is reflected in the structure.
And I think also, just from Councillor Albert's comment before, we'll put something in about the link between emergency and elective care,
I think that would be great.
just so you can see what it is or isn't.
Thank you very much. Lucy, did you?
I'm actually okay.
Thank you very much. Any other questions, colleagues, from anybody before we move to recommendations, which we just heard about? Anybody? Okay, so now we just focus on recommendations. We already mentioned recommendations from Ben and Concha. Are there any other recommendations that you want to make to our colleagues here? Okay, so Chetan, you have captured those recommendations.
And the information requests.
And information request. Great, thank you very much indeed. Okay, great. Now, thank you very much to all three of you for your very helpful replies to a number of questions that were put to you. So we move forward to the next item, which is the tracker for the recommendation. And Natalia alluded a moment ago at the start about a couple of items that she flagged up. So that is work in progress. And then we talked about the May meeting, and we will be meeting. Where are we meeting?
Hammersmith and Fulham.
Okay, so Natalia, so you're hosting us, so we look forward to coming to Hammersmith and Fulham for our next meeting. So, colleagues, I'm not aware of any other urgent business. Is there anything? Yes.
On the tracker.
Yes.
There appears to be so what seems to be a theme. I wasn't here, but just looking through the tracker.
So the Natalia was alluding to the point that a couple of items that she referenced were outstanding, and
Yes.
Chetan has confirmed that there is work in progress, and that information will be circulated in a short period.
That's fine.
Okay, so
July 24th, the muscular sclerosis one.
okay.
I'll chase.
Yeah, that would be
Great.
Thank you.
All right. Thanks. Any other items under any other business, colleagues? All right. So until next time, thank you very much, and we wish you a safe journey back. Until we will meet again next time in Hamilton and Fulham. That's fine. Very well.
I'm looking around there.
Yes. I didn't expect that you were in any closing remarks, but